Thank you very much. I'm glad to be here again. I think communication about what we all need to know is really important. And I wrote this word up, passionate. We're not having a soap opera today. This is not but passionate is how I feel about my patients. And I'll specifically say that every patient to me is no different, and this includes all of you, is no different than if it was my sister or my mother or my brother. There is no double standard. And this is one of the things that really frustrates me when I come up and I find out things are not being done as they should be. And I think you will agree with me that you would treat your parents and your siblings that way. I find it so important to keep that in focus. Yes, things are frustrating. You know, we all have frustrations in 2005, but so I'm very passionate about what I do and how I care about people and how I care about you all. The second thing that I wanted to mention here is sometimes we put this aside because we're so focused and we have blinders on. And excellence in what we do is so important, to be thorough, to keep up with things. You know, you fix your child's lunch before they go to school. You just don't send them off without breakfast or lunch. That's excellence in child rearing. You learn when to say no to a child. You're not there to make a popularity contest. You're there to mold him. If your nanny is not doing it, then you probably shouldn't hire a nanny. But it's a personal thing with parenting. And I think this is an issue that we need to pay attention to as far as excellence in what we do, either outside the hospital or inside the hospital. I am very focused on my patients and in the hospital and outside the hospital. I think it's very, very important. The opposite of that is mediocrity. And mediocrity is just letting things go, not paying attention. You come to, you don't polish your shoes, you don't brush your teeth, you don't take care of your kids, you don't send your wife or husband a Valentine's Day cards. That's mediocrity. That's opposite of passionate. Well, the point is that you can slide through life and let it happen or not. Someone asked me a question. I mentioned something to me the other day. In your life, and this is a very interesting question, in your life, do you let events run you, or do you run the events? Think about it for a second. Do you let the events run your life, or do you take charge and control those events? I take charge and control those events. I have to, because that's what I do for a living. Along these lines, there's a team. Our team is the physician and the nurse, and that's been that way for me for 30 years. And I think the team is so important. You guys are my right arm. You really are. And what happens when my right arm doesn't work? I try to rehabilitate it. I try to fix it. I try to do something. I'd say my right arm because I'm right-handed. That's the most important. I'm not going to say left-handed because that seems to be sinister at times, and I don't want to use that. But I think it's really important to realize that we are part of a team, and we have to think in terms of what the other part of the team is thinking, which is what I'm going to talk about a little bit today. And this is going to keep you from nodding off here after breakfast. It's going to require a little participation. But I think one of the things that Now, in order to be the right arm and anticipate what the doctor needs to know, I think we have to go back to find out what the nurse needs to know. Can someone give me a suggestion? I mean, let's say I have a patient that's had surgery, and I just want to find out, this is one of an exercise of thinking and speaking. Speaking is part of learning, and I thought maybe to have a little participation would be helpful. I can fill in the blanks, but I think to have someone say it would be helpful. What are some of the things a nurse needs to know about a patient? Okay, that's excellent. Right.
Anatomy and physiology.
Right. Yeah, normal for the patient. If he's 85 years old versus 25 years old. Activity levels, I think, would be one of the things we talk about.
We need baselines too. Baselines.
Yeah, that would be come in. That would come in with the normalcy, which, and much to my chagrin and yours, is hanging around your neck in the form of normal vital signs, which I think is just unbelievable. You know, if you guys are competent nurses, you don't need to know what normal vital signs are. And I think it's not a very supportive comment from the administration, but that's a different story. What else do we need to know? I mean, this is like, I'm going to go over this a little bit.
After you know the normals, you have to know what are the signs and symptoms of an abnormal finding.
Right,
So that
right.
we can move forward.
And that would be found through what specifically? What?
Patient assessment.
Right, patient assessment. And with that assessment, specifically with the assessment, what are you looking for?
Blood pressure, heart rate.
Okay, vital signs. So blood pressure, heart rate. What happens when there's a lot of blood loss? Blood pressure, heart rate goes up. Real simple, but it's something that we all are aware of. Okay, so vital signs, and I think what's more important with the vital signs, when someone calls me and they said they just came on shift, and they're calling me because the blood pressure is up, what's my first question? What was it before? So knowing the patient clinically before you call is important. So we're talking about trends. What's going on? You know, what is the trend for the vital signs on this patient? Well, if the patient's had a 180 systolic for the last 2 days and you've been gone for 2 days, you come on at 7 o'clock in the morning and the blood pressure's 180 systolic, you know, that's something that is somewhat, it's not normal, but it's not a big change. And that type of information really helps me immeasurably in figuring out what's going on. What else? Allergies. Well, allergies, right. If there's a trouble breathing or there's a rash, then the allergies come in, and that's a subset down the road. That's good. You?
Well, I was just going to say assessment for the efficacy of the surgery, because if you know what the surgery is for, you need to know if it's working or not working.
Okay, and what things would help us determine that?
Hematoma to a surgery site, evisceration.
Evisceration? I hope not in my patients. Jesus. You're scaring me now. I don't know.
No, I've seen it. This is stuff like
Not with back surgery, I hope. Well, with hematoma, what does that mean?
bleeding underneath.
And what do we check for bleeding? What do we... Labs, H&H, right. So we got a hematocrit hemoglobin, okay? That's right now. Again, what is it? We need to do a trend. So someone who calls on a hematocrit or a hemoglobin, and I asked them, well, what was it the last time, you know, or something like that, and they can't answer that, then you need to go back and we need to, in order to communicate, make your life more efficient, make mine more efficient, then you need to be aware of the overall picture of what's going on. That's very important. But you're right. Hematoma and all that's important. I've got a bunch of things here. I'd like to go ask somebody else, can you think of anything else? This is a fictitious patient. I'm thinking in terms of spine surgery. Right. Right. So we got neurochecks. And I usually write for neurochecks at least for 48 hours, every 4 to 6 hours after surgery. Now, I'll tell you a story. I had a patient who I did a laminectomy on, 4 or 5 years ago now. I guess it was 2001, 2002, maybe 2000, I can't remember. And I did a laminectomy on him, and he was in the recovery room, and he got transferred to 2 South, and I did finish the surgery about 2 or 3 in the afternoon. It was a 45-minute procedure. The nurse called me at 9 o'clock that night. Patient can't move his legs. Now it's been 7 hours, 6 hours, 5 hours have gone by, and nobody said a word. So I rushed in here and ended up, long story short, he got out of that, walked out of the hospital, he's fine, everything went well. And I'm not going to go into details of what the issues were about, but didn't work. The system didn't work at that point. I should have known much sooner, like at 3 or 4 in the recovery room, but that didn't happen either. So neuroscience is very, very important, and trends for neurochecks. Now, what does a neurocheck mean? If this is a foot, okay, and someone moves it and they go like this, but they can't go like that, there's a big difference between, there's one whole different nerve between this way and this way as far as the foot's concerned. And just because somebody can wiggle their toes a little bit, that's not really helpful. Now, I don't know the depth of training and anatomy-wise, and I don't expect more than what we can expect, but does anyone have a understanding about that, or which nerves go to what part of the legs? There's like 3 major nerves go to the leg. You know, you can hold the knee out, you can hold the leg up, you can raise the foot up and push the foot down. Actually, that's 4, basically. And that's an important thing. What other neurocheck can we do to check on sensation? And that's real easy because, you know, you can take either a pin or even a paper clip. It doesn't have to be terribly sharp, but if it feels like a piece of wood, then they can't feel it. If it feels like, yeah, I can feel the point of that, then they can feel it. And it takes about 2 seconds, and it makes a world of difference when you communicate what's going on with the doctor. Go past neurochecks. What else? Yeah, well, pain is... now, I think pain relief is excellent. Along with pain relief, we go to do what relieves pain. It's pain medications. So trends as far as they're requiring more, less, is it not working? I get on the floor at times and I get calls that someone never got their pain medication. In fact, I had one patient had PO medications and they interspersed one that we know didn't work, and the pain got out of control overnight. Specifically OxyContin versus Percocet. We have a lot of people who have medication needs right now because they in the past had probably had some errors of their behavior, so to speak, and they have spooled their liver up to where they handle these harder drugs faster, and so therefore the medications like Darvocet and Vicodin that will help us won't help them. So we need to be really on top of that. In the first 24 hours after surgery, it's so important to control that pain, because if you don't, then you have a problem handling it afterwards. And if you get moved, and this is something that happens in this hospital, you get moved from shift to shift and floor to floor, the continuity is broken up, which is all the more reason to pay attention to the overall picture of what's going on with the patient. So pain medication is I put, again, the trend. Now, what else for output? Okay, I'm going to start over here. So we get I and O. I had a patient the other night in, what's the step-down unit called? I don't. PCU. I'm sorry. It's and I asked the nurse, and she had trouble computing how much urine output per hour. And it took 3 or 4 questions. In fact, I think I was even there, and I asked her, well, "What is this?" And you did not divide over 8 hours. You'd usually divide 8 into whatever the number is, and you can get what it is. So if you got 30 cc's an hour is a minimum, and you multiply that times 8, you got to have a minimum of 240 cc's out over 8 hours. I mean, these are simple exercises, but sometimes they hit you in the face, and you just, if it's less than 30, this lady had 24 cc's an hour, an elderly lady, and there's a problem, and so we bumped it up, and with the fluid bolus, it worked. But it took a lot of questioning, and and I don't want to make anyone feel uncomfortable, but the information we need to know. It's very important. What else would be an important thing with post-operative. I'm thinking of a post-operative patient, as far as you call me and tell me how things are going. Okay. Okay. That's true. Most of my patients, so I'm talking from spine, I can't discuss other things, they have an ileus. They will have an ileus. They're usually NPO. If they're passing gas or you listen to their abdomen. How many here have listened to the abdomen and heard bowel sounds?
Every single
Okay. I know. No, that's fine. I just want to mention that because I'm not trying to be oversimplifying, but I'm just going to go step by step. One of the things that I think is important is assessing activity. You know, I have a couple of weeks ago I did 4 small cases, and I'd asked for the nurse. I wrote in the order as 8 o'clock and a 9:30 or 10 o'clock case to get the patient out of bed to pee, to void, and all that. Get them moving that day so they can go home the next day. Well, they never got out of bed all day long, and they didn't get out of bed till the next day. That's my wife, and I'm going to call her back in a minute. So anyway, I think it's really important to see all these things. Now, I want to go, this helps you with the overall picture of the patient and what's going on. Now, I'm going to erase all these, but we're going to go through a similar thing. And I'm going to write what the doctor needs to know, okay? Now, I don't know if this is too primary or too basic, but if you call me with something, you know, it has to be more pertinent to what's going on. I think just to think about what does the doctor really need to know about a problem. You know, let's say someone is having pain on the floor and someone calls. What's the first thing you got to do?
The pain medication you give is not, you know, effect, so maybe you change something.
Right. But what do you call when you call the physician on the phone? You know, to give him some simple information, some parameters by which he can make a decision and facilitate your care as the right arm for the patient. Yes? Right. Now, generally, it's my surgery, and you're right, but I think that's very good because that shows me you understand what's going on. And the important thing about it is you know, Dr. Nordt, you receive the medication and the frequency. If the patient is written Q to 3 to 4 hours, but they didn't get it for 6 hours, that's important. Then I know that the medicine's probably working, and your assessment as to the pain relief the first 2 or 3 hours, when you ask them that, is very important. If I find out it's been 6 hours, then it's too long a gap. And that medicine probably does work, so we don't have to change it. I'm just trying to think of how I think, okay? That's what I'm just, you know, so we can kind of get in the same wavelength on it. The pertinency to the problem, a lot of times I'll ask somebody a question, and somebody, generally this happens a lot too, and it's just reality, but somebody calls and, well, the nurse is on break. And so therefore they don't really know the patient that well when I ask a couple of questions. And I guess we'll just have to kind of work through that, I think. If you did know the patient, or when the nurse left, she gave you a couple of bits of information, then that would work too, okay? It's the communication between you all, and it's really important. So really importantly, we talk about the overview of this patient and how they're doing. So I think one of the things that helps me as a physician, and I don't talk to other physicians, you all do. I'm sure you get reactions from A to Z with other physicians, and I'm not going to go into detail, and you all act as sort of a cushion for that, and I'm sure that shapes your response on the phone many times, and I'm not going to go into that. But if you identify, there's a nurse that used to be here many, many years ago named Helen Pratt. I don't know if anybody remembers her or not. I've been here long enough to where I think I'm the only one. But she used to answer the phone. Helen Pratt, RN. I knew who she was. I knew, and she was very good. She answered the phone. She was an RN. If someone says, this is Susie Gutierrez, secretary, then I know that I can't give her orders. Many times I'll call and I start giving orders. Well, just a minute. And I'm on my cell phone because I'm trying to be efficient. And I drive all the way from this hospital to Baptist or to my house or something, and I'm still on hold. And the point is these little devices really provide an incredible amount of efficiency, but my personal opinion is they also allow us to do things and not plan our lives, because we can change it momentarily, just like the TV changes every 3 to 4 seconds. So I think to try to think of how we can efficiently handle this is important. So when you have all the information together, it's really helpful. And Helen Pratt would identify herself. I think identifying yourself as to who you are helps me a lot. Then you go through what the doctor needs to know pertinent to the problem. Leg pain. The patient has pain in the leg now. What would be the question? What would be the information you would be able to give me if they have leg pain that's new to you? Location. Right. What? Yeah, constant or versus intermittent? Right, right. New or old? I think that would be a very good question. Someone mentioned DVT, okay? Yes, right. So if you have swelling and tenderness and all that, obviously that would be of some concern. And if you, just because you just started on the shift and you've been gone for 2 days, if you ask the patient, was this present last night? You know, or when did it start? That's really important. And if that's the case, I had a case, well, let me tell you, the incidence of thrombophlebitis and DVT in spine patients is literally 0.5%. It's very small. The incidence of DVT and clots in the leg and everything in a total knee is about 40%. It's very high. The number one reason for medical malpractice suits in this nationwide right now is thrombophlebitis and DVT. I mean, just to give you some perspective of what's going on. And everybody loses. I went in yesterday to see a patient of mine, and the Plexipulse that I'd ordered was sitting on the corner on the floor. Now, I just talked to the nurse manager, and I said, just take care of this. I mean, this happens repetitively, but that's looking at the big picture. I had a patient, actually with Mrs. Lynn, and I usually don't make rounds on Sunday unless I have to come in. I try to take some time with my kids, but she told me about this leg pain on this patient. I said, just to be thorough, we got a Doppler, it was positive. And they could put an umbrella in him that afternoon. He went home the next day. Didn't even, not a peep out of it. So, but you are my eyes and ears, and that type of an assessment is very, very important. And basically, again, looking at the big picture, not just when you came on, but the trend. If you're at the end of your shift and you've watched this deteriorate or increase or worsen or whatever, that helps me. But if you talk to whoever it is and they tell you, well, you have a little leg pain, ask them, well, how long has it been going on? Have a curiosity about that. This is part of the excellence that we talked about. I think it's really invaluable to the physician to be able to speak to them and give them the information they need. Again, what the doctor needs to know. Now, people can rattle off diet, how much they ate, and all that. Is that going to affect the leg pain? Probably not. Okay. If the IV infiltrated, that's nice to know, but to save you the time and save me the time doesn't make any difference, as long as it's fixed. I&O, again, I don't need to know that if it's adequate. I set the parameters, at least in my orders, of 30 cc's an hour, and generally within 48 to 72 hours, it's resolved. So that's important. But is there any way, and I'm going to ask this question, it's an open-ended question, is there any way that the physician, when you call him, can help you with how things go, or anything we can talk about today? Because I think the communication does go both ways. Is there any suggestions from the doctor's standpoint? I mean, is there any suggestions that if you call me and I pick up the phone and call you and talk to you, is there anything I could do to facilitate that information exchange? I don't have the information. I do know the patient usually, unless it's somebody. Yes?
I don't know as far as when I'm on the phone, but I'm a really literal person, so when somebody writes orders, if they want something done a certain way, if I don't know that person and it's not written that way, I say, well, I'm used to it. Well, this person's professional and I trust their professional judgment.
So are you, though?
That's what they wanted.
Okay.
If that's what they wanted,
Yeah.
then that's what they would say.
Right.
So if it's not written that way, but then, you know,
Well, that's an interesting point, and I think most doctors do write exactly the way they want things. And medicine is an art. It's a science, but it's an art, and everybody has their way of making things work for them. That includes nurses and doctors. Let me ask you a question. Since you're a very literal person, if I gave you an order to start a clear liquid diet on a patient this morning, if I didn't write it down, would you do it?
get started with the diet.
Yeah, but I didn't write it down as a verbal order.
Is there no other order written?
Well, I didn't, the patient's been NPO for 2 or 3 days. I'm just trying to see what your perception is of what I say.
I wouldn't give them the food liquid, especially if it's 2 or 3 days, but if they did APO and they said, I'm really hungry, I would ask you
No, but if I gave you the order,
to give them clear.
I gave you the order to give the clear liquids and didn't write it.
Oh, then I'd write a verbal order for
Okay, all right, I was wondering, does everyone agree with that?
I would listen,
The what?
listen to that, make sure that they're capable of it.
Yeah.
But yes.
I would ask you before you left, you wanted to write.
Well, generally, my criteria,
Just write it down.
my criteria is if they're passing gas,
Yeah.
I'll give it to them. And let me tell you a little bit about that, just for what it's worth. When you do a back surgery, and we'll get back to you, I think your comments are great. If we get back to, if I do a back surgery, the patient has an ileus after surgery because the retroperitoneal parasympathetics, which control the bowel, are disturbed a little bit. And within a day, even with a simple laminectomy, this can happen. So all of a sudden, if you talk to someone, they're usually belching because everyone swallows a lot of air during the day. And when they eat and drink, they swallow air, and that either goes out one way or the other. And if it comes up and they're belching, that means it's not going through. Okay? So I can listen to their bowels, and if they have bowel sounds, that's one thing. But if you have peristalsis here at one end of the tube and nothing here, and you give them something, a laxative, the peristalsis gets worse. This is actually stressed and doesn't start on its own, and you don't have any gas coming out the other end. So therefore you have a partial ileus, which is what I see mostly. You can hear bowel sounds, but until both are moving synchronously and you're passing gas, I usually don't feed them. And I think you can give Ducalox suppositories. Mrs. Lynn has her concoctions, and I think they work. I mean, they're wonderful. But I'm always afraid of someone getting sort of bound up again, and I'm not an expert in ileuses, but I did learn when I was a medical student from a fellow who's passed away now, who's very famous. Let nature take its course. Don't push it. And I think that's my philosophy. So if someone's not passing gas, I would hold off on a diet. But if you're making rounds with the doctor and the patient says, yeah, I just passed gas this morning, I won't even listen to him. I'll just go ahead and start him on a clear liquid diet. And that's where the verbal order would come from. So therefore, if you wanted your comments right, if you wanted to listen to see if they have bowel sounds at that time, that would be good. But it's just, I think what I'm going through, these are minor things, but they're all how the thought process works and how we communicate as nurses and physicians. And I think that's the most important thing. Yes, ma'am.
That's fine to that degree, but what I find happening a lot is that someone will hear a verbal order but forget to transcribe it, and then the next shift comes on, and you're hearing third-party information, and
Right.
the order's never written,
Right.
and then you almost have to go back to the first person who wrote it. So I like that idea to trigger that we should,
Yeah.
if you hear a verbal order, like enact it.
Yeah. If it depends on the circumstances. If I have a nurse with me and we walk in and see the patient, and then I have a chart and I write all the stuff and I walk out and I say, oh, by the way, I forgot to write a clear liquid diet. If you write it right then, that's one thing. But if I'm making rounds by myself and you're on the phone and you got a chart and you're doing 3 things at once and I give you a verbal order, chances are you probably aren't going to do it because you're going to be distracted. And so having the nurses make rounds with the doctors, if you can do it, is really helpful, because then we can teach each other. It's a time-honored way. It's the way we learn in residency. I'm sure you all made rounds on patients, and so you understand the disease process, you understand the thought process. Christ, every doctor is different, every nurse is different on how you perceive, how comfortable you are. If you're not comfortable, you ask a question. It's just a part of a constant learning process. We're all students. It's a constant learning process.
When I deal with verbal orders that doctor is there, I really don't write it. I'll let you guys write it. I'll physically bring you the chart, and I'll say, okay, could you just please write that for me?
That is an excellent way to do it. But see, she solved your problem by doing that. But she's taken charge of the decision and the responsibility by bringing the chart to the doctor. Would you just write this real quickly for me? And that's that solves the problem of is it or isn't it and forgetting it. That's an excellent suggestion. Yeah, that's exactly right.
Exactly what you want.
Yeah, I think that's exceptional. It really is.
Can you restate what you just said?
Yeah, she says that that if a doctor gives a verbal order, that she will bring that chart immediately to that doctor to get him to write it, so it's very clear that it's on the chart, and it also avoids the matter of her getting distracted and not writing it down, and then the next shift comes on and it gets forgotten, as was mentioned over here. So I think that's an excellent solution, but she's taken charge and responsibility of that decision-making process to implement the order, and I think that's important. And that's true of almost anything. So congratulations. That's right. Yes, ma'am.
I have a question. Yeah, verbal order speaking so much so often. I mean, whether have any kind of policy to say verbal order have to be signed by the doctor after 24 hours or 48 hours, whatever makes the policy. I mean, how many hours do you have such kind of policy?
I think it's 20. I think it's the question. The question is it about signing the verbal order with 24, 48 hours? And in this hospital, I think it's been standard 24 hours to sign a verbal order. I rarely see them in the medical records, because I usually do them myself the next day if they're right there on the chart. But 24 hours is generally the rule. So let me ask you another. It's just sort of, again, along the lines of taking the responsibility of what's going on. And this will be one of our last little things, but it's more of a perception, I think, than anything else. And this sounds silly, but getting the patient out of bed. If an order is written to get the patient out of bed, and the patient refuses, what do you do?
Explain to the patient how important to get out of bed.
Exactly, right. And the question, okay, she answered the question to explain to the patient how important it is to get out of bed. And my question again was, what happens when the patient refuses? Now, I had something happen a week or so ago. I had several people actually in the hospital. There are more outpatient surgeries, 23 hours. And the thing is, if you can get these people moving that afternoon with a surgery that morning, then they've already been up once. All the blood's gone to the legs. They're moved. They're not getting dizzy. The legs are working. They have personal confidence that they can do that. They maybe sit in a chair for a while, then they get back in bed, and they find, hey, I can do this. The next morning, it's a lot simpler. And then they go home. I had a patient that it wasn't done all day on an afternoon and an evening, and the bottom line is the next day I got him up, he's a little dizzy. He ended up going home, and a lot of my patients come from the Keys. This guy went home to Marathon. He's doing fine. But the thing is that physical therapy is not, and they're hit and miss around here sometimes, and I hate to say it. They're good when they're there, but sometimes they have priorities, and I don't know what those priorities are, but I sometimes get frustrated, and I'm sure you do too. But I don't want you to hurt your back. I don't want you to do anything extraordinary, but just to sit down, as Mrs. Lynn says, I mean, literally sit down in a chair next to him and talk to him and say, look, this is what needs to be done. You're probably going to go home tomorrow. That's the plan, because you know the patient now, and this is what we need to do to facilitate your going home.
As well, that we need to put the ball in their court and say, what did the doctor tell you?
Absolutely.
What did you learn?
Absolutely. Absolutely, and I'll back, at least personally, I'll back you guys up 110% on that. But I do know that there's some issues where people walk in and say, well, I don't want to get out of bed, and the nurse turns out she's got more things to do, and she won't talk to them, and she'll go off and out the door, and they just lay there until the next morning. And I think I'd like to avoid that. Now the hospital doesn't, I'm pretty efficient with my patients. There's a whole issue with economics in the hospital and getting people out of the hospital efficiently. I don't worry about the money. I worry about the danger. Being in a hospital is dangerous, period. It's just, that's the way it is. Things happen in hospitals. People fall down. They injure their feet. They have fractured hips. I can tell you stories from 15, 20 years ago. But so to move this process along and get them out as a team is so important. So sitting down, as you say, is excellent. I think you're absolutely right. And tell them, put the ball in their court. Says, your doctor has written this order. This is what your surgery was, and the last 10 people we've had up here, you can embellish it a little bit, but the last 10 people we've had up here have done very well, and you need to get out of bed, because once you get out of bed, you'll find out that everything works. I like you. You're right. Yeah. Yeah. But it takes, but what that takes, what she's saying is true, but it takes a little effort, a little time. Currently, how many patients are you guys taking care of? What's the number? 6. Okay. I'll have you know that, how much, 7? I tell you, in 2002, summer 2002, this hospital, the nurses were taking care of 12 to 14 patients. Okay? And I went around with another physician who was chief of staff at the time, and I kind of beat the administration over the head 2 or 3 times with 2 or 3 meetings, and we've basically got the nursing patient ratio down to 7 to 1, 7 to 8 to 1. And then about 6 months later, I was complimented by somebody, I'm not going to say who, you know, you're right, because now it's become a national standard. Here 2 years later. It is absolutely impossible with sicker patients for the nurses to render the care that they've been professionally trained to do. And so therefore, it just got to stay at that. And it probably could go down to 4 to 6, actually. I know. Well, see, and you have the balance of patient care and then the people that are running the hospital, which are not doctors anymore, unfortunately. The administrators, and money is more important. And so I think until something happens catastrophically, it's going to probably stay there. I think 4 to 1 is excellent. That would give you guys the ability to do the what? Total care. Yeah, that's right. And you know the patient. So when you pick up the phone, we don't have to go through all this. Because of the scheduling of the nurses, and correct me if I'm wrong, but you move from floor to floor, shift to shift, and there's less continuity of care than I'd probably like to see. Is that true or not?
Not consistently, though. They usually are assigned, the full-time staff are usually assigned, and there is some floating to cover staffing needs. Routinely, they're not loaded every shift, every day, 2 different units.
But how about the shift? I mean, I'm not going to tell. I'm not trying to tell people how to run the hospital, but I think as long as we can keep a nurse with the same set of patients on the same shift, on the same floor, or at least go in that direction, I think that's what I'm trying to talk about. I'm not going to sit and.
It's pretty much consistently done.
Okay.
With the full-time staff.
Okay.
That's on a particular unit.
Yeah,
The only reason
that's
that
perfect.
would be deviated was if there was a particular unit
Right.
that happens to be short, and so what we try to do is balance the staff to try to maintain those ratios.
Right. No, I think you're.
We like floating, and we try very hard not to float the staff all around.
No, I understand. This isn't supposed to. I'm not trying to be. I'm not grading anybody.
Explaining to
I think that's great.
our rationale.
I think we're going in the right direction from what you're telling me, and that's great. That's really encouraging to hear. So I'm going to quit right there, okay? I'd be happy to answer any questions. I think we've kind of exercised our brain and our thought processes a little bit, but there's some doctors that rush in and rush out. Let me finish up with one thing, is that there was I've been around longer than I probably care to remember now, but I started practicing in 79 and 80. I was on staff at the University of Miami for 2 years. Thanks. God, he's killing me. But I got on staff here in the fall of 80, early 81. So I've been here for 25 years almost. And the bottom line is when you came on a floor, and this is what the nursing profession was like, and this is Mrs. Lynn, sort of the dinosaur here. But when you came on the floor, the nurse, the charge nurse, was insulted that you didn't talk to her before you went to see her patients. And that's the way it was 25 years ago. And she actually would dress you down. She says, yeah, you did not call me. This is my patient. And you would make rounds. She insisted. That was the profession of nursing. It wasn't just a job. It was a profession. And I think I respect every one of you as a professional in what you do. You've been trained. You're taking care of very precious people. And I don't know if we're ever going to get back to that, but taking a personal interest like this young lady over here and making sure things get done is very important. And I think making rounds with a physician, if you know the guy well, fine, but I think making rounds to doctor, what are your plans today on this patient? You take him by the arm and you walk to the floor and walk to the room and say, doctor, let me get the chart for you. And I'm asking for communication. This is a form of communication with the changes that go on. I don't know who's taking care of my patient today. And unfortunately, you guys know me better than I know you. So, but I think that type of help would be very, very appreciated by me, and I'm sure the other staff. I think they would be amazed. So it's just a suggestion to try to get back to some sort of a control and understanding of the patients. Questions?
I just have a comment. I appreciate everything that you have said today. Just to refresh everyone's memories, the number one reason for sentinel events in hospitals, what is it? Who said it? Someone said it. Communication. Exactly, Carmen. So we are all here for our number one reason is to deliver excellent patient care, to keep our patients safe.
Right.
I remember sentinel events, the number one reported reason why they occur. Does everybody remember what a sentinel event is? Okay? If you come into the hospital, let's say, for appendicitis and something terribly goes wrong and you end up maybe having respiratory cardiac arrest, you did not plan on coming in with that happening. The number one reported reason why sentinel events occur is communication. So I appreciate you coming today. And
Well, the communication is everything.
On it because we're all here to keep our patients safe
Yeah.
and to give great quality care.
Absolutely. Absolutely, yes.
Dr. Nordt, when you asked the question about what we expect back, from the physician, I think to go along with what you were saying.
Thank you for answering, because I didn't get any answers.
I think that one thing that is real helpful is that you talked about wanting somebody to make rounds. I think that's really good and that to be utilized as a communication opportunity. Then that needs to be passed on because from shift to shift, what your discussion was, so that it can be a better continuum of care.
Right.
So that when somebody has to call you in the middle of the night because there's a problem, then you're not so angry because they know what was communicated and what the plan is, and that's the best way that they can facilitate that communication with you.
I think I agree with you. There's either 2 12-hour shifts or 3 8-hour shifts, and I make rounds every third shift at least or every other, depending on what the frequency of the shift is. But I think that's important. If you're really paying attention to this patient and you only have 6 people, if you know that patient, you're absolutely right. You can communicate that.
Working with you
Right.
to learn, even though I may be the one that makes rounds with you because I'm the one assigned to that shift, by continuing to use it as an education for the other people taking care, I think that it's a win-win situation.
Right.
For the patient.
Oh, absolutely.
For us working together.
We have the ability in this hospital, with our location and the quality of what we have, to make this what we call a 5-star hospital. Not a 5-star hotel, but a 5-star hospital. The anesthesia here is the best in the city. That's why I come here. Because I have difficult patients, and I, knock on wood, I've never had a problem with anesthesia here. It's been unbelievable. The nursing care is very good. You compare it to the other places, and we're way ahead. I guess I'm a perfectionist, and I guess I really would like to see this to be the best place to be, and I choose not to go anywhere else. I'm here for the duration. So,
I just support you in your, help, continuing to help educate the staff with what your expectations.
well, I think that's important.
And follow through.
Yeah.
When they make rounds with you so that you feel like you know what the plan of care is and the person that's working with that patient.
Yeah, making the rounds. Communication does not take place in the chart. Unfortunately, even though the lawyers would like you to write everything down, it does not take place in the chart. It takes place between two individuals. You're just not going to go, I'll read nursing notes occasionally if I need to find something or something. But generally speaking, if I talk to one of you and you talk to me, we know what's going on. And that is written in a progress note, yours and mine. I think that's really important. So, but thank you for saying that. Thank you for the comment on the communication, because that's basically the issue right now. And it's deteriorated. It's got to come, the communication has got to be enhanced and encouraged by everybody.
Because I don't think that all of the staff know you and can appreciate you like some of us know you, that you're willing to teach.
Oh, absolutely.
And pass that information. And I know that some people are apprehensive because they don't know what you expect. And so if we can utilize these opportunities to teach more people so that it's a learning opportunity, so that we can exceed your expectations, so that the patient is the one on the receiving end.
Absolutely.
Of that care.
Absolutely.
That's what I think that we
No, I agree with you 100%.
need to work with you and any of our physicians better.
Absolutely. I would suggest, in light of what you said, is maybe in 2 or 3 months, let's sit down. You guys write things down. We'll all contribute, and we'll get back together and talk in 2 or 3 months. I mean, sometime in May or something like that, or April, whatever would be appropriate. I mean, we can contribute to each other's knowledge base and education based on the experiences we've all had.
I think one of the important things that we all have forgotten to mention is the time element. I think everybody today appears to be, or is, too busy. And it's time that we gave each other time. Instead of just talking about giving the patients time, which is our paramount thing, obviously, we need to give each other the time to communicate, which we don't do.
Right.
The doctors split in, the doctors split out. I work on nights, so I obviously don't see it as much as anybody else.
Yeah.
But we don't have that time.
The comment is we don't have the time, the doctors and the nurses don't have the time anymore to communicate, but I think we need to put the brakes on, dig your heels in, and slow down a little bit and just talk. And generally speaking, once it starts, it becomes a very efficient, short conversation. But it's a conversation.
We don't have time to do it right the first time, but we certainly have more time. It's going to take to correct it.
If you don't do it right, then you end up with a sentinel event like she talks about.
I mean, I know we simply don't have time.
And then it's a crisis, not a planned event. And that's a big difference. But thank you very much. Yes? Wait a minute, here, one more question.
What do you think about the patient you did surgery on, and when now the nurse working with that patient, and the patient said, I'm diabetic, I want to check my blood sugar before I eat, and you didn't know the patient was diabetic. So we call you, or we can go ahead and
Go
do
ahead,
another
test it.
Listen, no, doctor.
So the patient wants the blood sugar checked beforehand. I would probably, I don't treat diabetes. I can, but I choose not to, because if someone questioned me on my ability on it, I'm kind of a little weak on it. But I would probably get a clean, have a second void urine and check if they're spilling any sugar, for starters.
No, we don't do that anymore.
Okay. Well, see, that's how far off I am, okay?
So what,
And then if you do a blood sugar, you can just do a finger stick blood sugar.
we can just do it, we don't need to call you, or we need to
No, if they hire you, call.
No, you can.
That happened once, and it was an issue.
Yeah, if there's a medical doctor on the case, I'd call him. A lot of times I get called because my name's on the blue plate, but I can't do anything with the cardiogram or the heart medication or the blood pressure. I would tell you to go ahead and do a finger stick blood pressure, finger stick blood sugar on it. I don't know, remember the...
Before we do it.
Yeah, or, or even if, actually speaking, it's such an innocuous procedure, I have no problem if you did it ahead of time. I'm not going to get angry. You're giving me information, you're making it efficient, and you're communicating with me. And I think that's the question is if someone needed a blood sugar done because they said they're diabetic and they want to have it done and nothing's been ordered, would they do it a finger stick before calling me or after me? I don't know what the hospital policy is on that. I don't mind if they do a finger stick. What? Before. Now, drawing blood is a whole different issue.
ID will cost us.
Yeah. It'd make one phone call when you do that instead of two.
Because what are you going to say? Well, what is their blood sugar?
That's right.
Because a lot of times there's the ID.
Thank you.
The ID